PC Manoria is excellent speaker in the sense that we have heard from for so many years. And he is a director of Manoria Heart and Critical Care Hospital in Bhopal. Not only is that, he is the important cardiologist for all the top people in the state of Madhya Pradesh. His Excellencies and the Governor. He retired from the very high senior position at the head of Department of Cardiology, Gandhi Medical Hospital. And he is the past chairman of numerous societies and organizations, not in India, globally, such as APSC, SARC, API, CSI, ICC, and GSI, AFMC, and so on. I mean, there are so many of them that I can even remember and name all of them. Not only that, he is the past dean of Indian College of Physicians, Indian College of Medical Ultrasound, and he's been past editor-in-chief of, can you imagine, a Journal of Nuclear Cardiology Society of India. So Dr. Manoria, I'm really pleasure is for mine to introduce to come and deliver your talk to the audience, which is attending and eagerly waiting to listen to you.
Thank you, Dr. Amrish and Dr. Manisha. And good evening to all of us. I'll share the slides first. All of us know diabetes is a multifaceted disease with multiple pathogenetic mechanisms, which has been beautifully exemplified by the Ominous Octet of Dr. D. Franzo. For several years, we have been treating diabetes merely by a glucocentric approach because the conventional anti-diabetic medications just provide glycemic control and do not improve the cardiovascular outcome. But interestingly, during the last couple of years, we have new anti-diabetic medications like SGLT2 inhibitors, GLP-1 receptor agonists, which have shown improved CV outcomes in dedicated CV outcome trials and improved renal outcomes in dedicated renal outcome trials. These agents are hitting the current guidelines all over, and currently diabetes is now not merely managed by glycemic control, but we have also become cardiocentric, nephrocentric, so as to improve the cardiorenal outcomes of diabetes, which is the need of the day. It is thus obvious that for optimum management of diabetes, as Dr. Amrish pointed out, the cardiologist must get familiarize himself with diabetes and become cardiodiabetologist, and the diabetologist should learn cardiology and become diabetocardiologist. Time has come when cardiologists, diabetologists, and nephrologists should shake hands for optimum management of diabetic patients. Interestingly, the pharma industry is also following the same path and trying to disseminate the current approaches in cardiodiabetology. And I, being a cardiologist, have great interest in cardiodiabetology and cardiometabolic medicine, and therefore giving a talk on this unique combination of SGLT2, empagliflozin, and DPP4, linagliptin. In this combination, the empagliflozin, as we will see, is a panacea for heart failure and a boon for chronic kidney disease. It is powered to improve the trajectory of chronic kidney disease by further slowing the decline of GFR on top of RAAS blockers. The linagliptin, by inhibiting DPP4 enzyme, provides an incretin mimetic effect, and this coupled with SGLT2 inhibitors targets most of the component of the ominous octet and provides good glycemic control with minimal or no hypoglycemia, and also improves the cardiometabolic profile by decreasing weight and blood pressure. Now, all of us know India has around about 73 million diabetic patients, And it is projected that by 2045, type 2 diabetes in India will rise to a colossal figure of 134 million, making the country the highest diabetic prone country in the world. What is very distressing is that about 70% of the population are uncontrolled despite treatment. And all of us know the two major concerns at the present time of diabetes are a cardiovascular disease and a chronic kidney disease. Diabetes is a den of cardiovascular disease. Cardiovascular disease occurs 10 to 15 years earlier. It is 2 times more common, and a major chunk of diabetes, 52 to 80%, succumb to it due to a cardiovascular disease, mainly acute myocardial infarction. Cardiovascular risk reduction is therefore of immense importance, and we are running a race against cardiovascular disease for several decades. What is also very distressing is that subclinical disease is also common in diabetes, and about 70% of patients have subclinical disease. And if you have a subclinical cardiovascular disease, the risk of cardiovascular events would also increase. Now, there are several unmet clinical needs in diabetes, but the biggest unmet clinical need in diabetes is highly underutilization of new antidiabetic medications like SGLT2 and GLP-1, which are now powered to increase the cardiorenal outcomes. And we must train our practitioners, physicians, so that more and more patients of diabetes are brought under the net of these new agents so as to optimize the results. Increasing prevalence of type 2 diabetes is of major concerns. Risk of complication is also an unmet clinical need, but these newer drugs will try to minimize these complications, and glycemic targets in India are also very poor. Now, this shows the ominous octet of Dr. Di Frenzo. 3 hormonal systems and 8 organs participate in the pathogenesis of diabetes. Amongst the hormonal system, all of us know insulin, glucagon, and the incretin mimetic. So diabetes is not merely a disease of insulins, and you can see there are 8 organs which are participating in the pathogenesis of diabetes. Declining beta cell mass is inevitable in the long run. Now, before talking to you about SGLT2 inhibitors, I'd like to ask you one question. Which complication do you fear most in people with diabetes? There are no voting pads. Acute myocardial infarction, renal failure, heart failure, weight gain, and hypoglycemia. The answer is obviously heart failure, and heart failure. And let's see what are the reasons why we are so much talking about heart failure these days. Heart failure precedes the development of coronary artery disease. If you look at the natural history, first peripheral vascular disease, then heart failure, and then coronary artery disease. Unfortunately, in the earlier days, heart failure was not included in the primary endpoint, and later on it was realized that heart failure hospitalization is also a very important component. The second reason why we are pausing, once heart failure sets in, it runs a malignant progression. 50% of patients die at the end of 5 years, and if you have a diabetic with heart failure, the mortality is very, very high. 87.5% will die at 5 years. The 5-year survival rate is only 12.5%. The third reason is, if we look at to who gets hospitalized amongst the diabetic, it is heart failure, which is more common a cause of hospitalization than acute coronary event. And what is still very distressing is, despite control of cardiovascular risk factor to guideline-based targeted, heart failure can still occur in as many as 45% of patients, because diabetic heart failure is not merely due to an atherosclerotic cardiovascular disease. There are many other mechanisms by which they may develop heart failure even in absence of an atherosclerotic disease. And 68% of patients with type 2 diabetes had evidence of LV dysfunction 5 years after diagnosis, even in absence of CAD. So heart failure in diabetic could be a CAD or it could be a non-CAD. And what is very, very important is, unlike acute myocardial infarction, where you have a quick fix, you get acute myocardial infarction, you get primary angioplasty within the window period, and you can immediately improve your outcome. But for heart failure, there is no quick fix. We can only blunt the progression of heart failure. So heart failure is certainly of great concern in diabetics. I've shown you the survival rate. And interestingly, we have now this molecule, SGLT2 inhibitors, which is a panacea for heart failure, as we'll gradually see. Now, this shows the mechanism of action of SGLT2 inhibitors. All of us know that SGLT2 inhibitors inhibit the SGLT2 receptors in the S1 part of the proximal convoluted tubule, so that glucose absorption is inhibited, and this is excreted in the urine. And they have large number of mechanisms. Because of this, there is decrease in the body weight, an increase in the insulin sensitivity. There's also decrease in blood pressure, arterial stiffness decreases, decreased insulin secretion, and there is better glycemic control and decrease in the HbA1c. And in kidneys, they result in apparent arterial constriction, which decreases hyperfiltration, decreases also uric acid and albuminuria. Now, this is an overview of the SGLT2 three landmark trials which were conducted: the Empa outcome, the Canvas, and the Declare TB 58. Majority of patients in these trials were at risk of heart failure, and only a minority of patients had heart failure. And look at the results. Hospitalization for heart failure, Empa 35% reduction, Canvas 33% reduction, Declare 27% reduction. Cardiovascular death 38% reduction in the Empa, 13% in the Canvas, and 0.2% in the Declare. This difference is because of the subset of patients which are enrolled in the 3-point MACE, 14% reduction in the Empa, and 16% reduction, 14% reduction in Canvas, and Declare there was a 7% reduction. Renal outcomes were also immensely improved. We will see the details in a couple of minutes. 46% reduction in the Empa, 31% reduction in the Cana, and you can see a 45% reduction in the Declare trial. Now, when we look at the finer details of hospitalization for heart failure, Empa was a totally secondary prevention trial. All patients had cardiovascular disease, and you can see a 35% reduction in the hospitalization for heart failure. Declare TB was a mixed population. The trial as a whole showed 27% reduction, but if you have only multiple risk factors, there was a reduction of 36%, and in established cardiovascular disease, 22%. Canvas trial as a whole, 33% reduction. If you are a primary prevention group, you have a 36% reduction, and a 32% reduction if you are a secondary prevention group. So hospitalization for heart failure is decreased both in the primary prevention group as well as in the secondary prevention group. And look at this. The curves for hospitalization for heart failure start separating very early. You can see within the first month itself, they start diverging. And this is indeed a great achievement, because all of us know every hospitalization, every rehospitalization takes the patient closer to death and imposes a lot of financial burden on the patient, on the society and nationhood. So if a drug is able to decrease hospitalization for heart failure, this is indeed a great achievement. And SGLT2 inhibitors are powered to decrease hospitalization for heart failure across the spectrum of the disease, whether it is primary prevention or whether it is secondary prevention group. And this shows an amplification view of the Empa outcome, 3-point MACE, 14% reduction, statistically significant. Cardiovascular death, 38% reduction. It is very important to understand here that cardiovascular death in the Empa outcome is decreased because of decreased hospitalization for heart failure and not due to atherosclerotic complication. SGLT2 inhibitors do not decrease MI and stroke, and 50% of death, cardiovascular death in diabetes is because of heart failure hospitalization. The remainder 50% is because of atherosclerotic complication. So SGLT2 inhibitor decrease cardiovascular death by decreasing hospitalization for the whole cause mortality is also decreased 32% and hospitalization for heart failure by 35%. Renal outcomes are also very excellent, and we will show you the details. The Empa showed 39% reduction in new onset of worsening hypertrophy, but CKD is also becoming a very important target for SGLT2 inhibitors, and they are powered to take the trajectory of CKD, as we'll see in a couple of minutes. The benefits of SGLT2 inhibitors are executed by multiple mechanisms. There's no single mechanism. As you can see in the slides, they decrease glycosuria. So there's negative caloric balance, decreases total body mass, fat mass, epicardial fat is decreased, less inflammation, less fibrosis, decreased inflammation, decreased glucotoxicity, decreased plasma uric acid, decrease arterial stiffness, decrease myocardial state, and also calm down the sympathetic system. So there are multiple mechanisms in the kidney. They produce efferent arterial constriction, which decreases the interglomerular pressure and albuminuria and checks the declining course of CKD. Now, Empa-Reg or empagliflozin, you can see there are multiple mechanisms, and that's why the results were so good that it was approved by all guidelines for hospitalization for HF, for decreasing cardiovascular death, and these are big achievements of empagliflozin. And as we said, hospitalization for heart failure starts decreasing very early in the course of the disease. And Empa or SGLT2 inhibitors do not affect the atherosclerotic complication. They are affected by GLP-1 receptor. So how can we utilize this empagliflozin? You can utilize it for decreasing hospitalization for heart failure. And if you are already suffering from a cardiovascular disease, you can have reduction in cardiovascular death, you can have reduction in all-cause mortality. But if you are in the primary prevention group, you do not have these benefits. And we will see it produces immense benefit to chronic kidney disease. We'll see in a couple of minutes. Besides patients who are not in heart failure, who are at risk of heart failure, all these 3 trials have shown excellent results. The second subset of heart failure is heart failure reduced ejection fraction, and this also SGLT2 inhibitors. The DAPA-HF trial was released. The Emperor reduced trial will be released shortly in future, and all these trials have shown improvement in the CV outcomes of patients who are in heart failure with reduced ejection fraction. And the third subset, heart failure with preserved ejection fraction. Several trials are ongoing. The Emperor preserved with Empa, Deliver with DAPA, and it is speculated that these trials may also come out to be positive, because unlike all other drugs which have been tried in heart failure with preserved, all of them act through the neurohormonal modulation. This drug does not act through the neurohormonal modulation, and the data from the declaratomy showed that those patients who had heart failure with preserved ejection fraction, they also showed improvement. So we are hopeful that we will get the first molecule which will change the outcome of heart failure preserved ejection, but only time will finally tell what is. Heart failure in diabetics should be detected very early. Rather, if the patient is at risk of heart failure, he should be treated with SGLT2 inhibitors. Heart failure reduced ejection fraction is easy to diagnose. We also have heart failure preserved ejection fraction. Echocardiography can immediately discriminate between these 2 subsets, or if there's confusion, particularly among the diabetologists, they can take advantage of the natriuretic peptides. Now, this shows the benefits of all SGLT2 inhibitors. You can see all the parameters of kidney disease. The hard endpoints are favorably affected by SGLT2 inhibitors. So SGLT2 inhibitors are a panacea for heart failure. They are a boon for CKD kidney. And look at this, they've been tried in all subsets of CKD, and all these hard endpoints have been favorably affected by SGLT2 inhibitors. Prior to the RAAS blockers, which came in 2001, there was rapid deterioration of diabetic kidney disease. The decline in eGFR was to the tune of 10 to 12 ml per minute per year. So most of them will be shunted to dialysis very shortly. The first revolution in diabetic kidney disease came with RAAS blockers, where several trials with RAAS blockers have decreased the decline in GFR by to 4.5 ml per minute per year from 10 to 12. This was indeed a great achievement, the first revolution in slowing the progress of decline in GFR way back in 2001. And all diabetic kidney disease, as we know, are on RAAS blockers. SGLT2 on top of RAAS blockers, they have further slowed down this decline in GFR from 4.5 to 1.85, as you can see, which is a 58% reduction in the GFR, so that our GFR at the moment, with optimum use of SGLT2 inhibitors, still 1.85. The normal decline in GFR is about 0.9 ml per minute per year. So we have still not reached the goal. And interestingly, the third molecule which is going to come on top of it would further improve the trajectory of kidney disease are the non-steroidal mineralocorticoids, and the Fidelio trial and the cardio trial are positive, and they're going to be presented in the nephrology meeting in the United States shortly. The results are positive. So we have greatly improved the trajectory of chronic kidney disease, and less number of patients will require dialysis. Gliptins no doubt decrease albuminuria, but this is a biomarker. SGLT2 inhibitors are the clear winners in reducing the trajectory of kidney disease. No other drug has done it so far, the anti-diabetic medication. Now the blood pressure, which is lowered by SGLT2 inhibitors, it also lowers arterial step, natriuresis, weight loss. There are many mechanisms. Both the systolic and the diastolic blood pressures are decreased without increasing the heart rate. So there's no reflex sympathetic stimulation. Systolic may be decreased by 5 millimeter, diastolic by 2 millimeters. Weight loss, reduction in sympathetic nervous system. Then several other mechanisms contribute to antihypertensive. Plasma volume contraction due to osmotic diuresis, improvement in the vascular stiffness, which is very important in isolated systolic hypertension, reduced sympathetic nervous system activity, and somehow the uric acid is also decreased. There's also decrease in the body weight because there's excretion of 75 grams glucose per day, which approximates to 300 calories per day, are lost in the urine, and there's also diuresis of 400 ml per day. The total blood loss usually is 2 to 3 kg. Now they also produce natriuresis, and there's also improvement in the endothelial function. There's vascular stiffness also improves, and you can see a small trial showing reduction in central aortic pressure, central pulse pressure, change in the systolic 24 ambulatory blood pressure, and change in the HS-CRP, indicating they also have an anti-inflammatory effect. Interestingly, the uric acid levels are also decreased, and we know that a lot of data coming that chronically elevated circulating uric acid levels are associated with increased risk of hypertension, cardiovascular disease, and CKD. And uric acid in patients on SGLT2 inhibitors is decreased because of diminished absorption. There's increased excretion, and this is mediated possibly by the renal SLC2A9 transporter. So let's look at this combination. Now, when we combine both these drugs, you can see most of the contributors to the Ominous Octet are targeted. The DPP4 produces an incretin effect, as you can see here, and it decreases because of inhibition of DP4 enzyme. It prolongs the action of GLP-1 and other hormones. Then it also decreases glucagon secretion. It increases insulin secretion, and indirectly also affects the insulin resistance. There's also decreased hepatic glucose output, and the SGLT2 inhibitors, as you can see, decreases reabsorption of glucose from the kidneys. And if you utilize this combination with metformin, then it will greatly enhance the power of targeting insulin resistance, and this will counteract nearly all the component of Ominous Octet, because insulin resistance is best targeted by metformin at the level of the liver and at the level of the skeletal muscles. Linagliptin has established its cardiac safety, heart failure safety, and renal safety in Carmelina and Carolina. So linagliptin is a very safe drug. It does not require modification of dose even in patients with CKD. And again, the same thing is exemplified. If you look at sexagliptin, the atherosclerotic safety is there with sexagliptin, but it produces a 27% increase in hospitalization for heart failure, and its renal safety is uncertain. If you look at the teneligliptin, the CV safety is not proven, heart failure safety is uncertain, and kidney safety is also uncertain. If you look at the sitagliptin, good atherosclerotic safety, good heart failure safety, but the renal safety is not yet proven. And the linagliptin, you can see there's green light for all the three components. Now, when we combine both these agents, when you use Empa, you will have the advantages of 3-point MACE, cardiovascular death, hospitalization for HF decrease, and the renal endpoints. Linagliptin has good safety, the cardiac, the renal, and hospitalization for HF. If you look at DAPA decrease 3-point MACE in cardiovascular death, and sexagliptin is notorious for increasing hospitalization for heart failure, which we'll never like to have in our patient. Its renal safety is not established. Surprisingly, the Vertis CV trial where atugliptin has been negative. It failed to show superiority. The trial is going to be presented in future, and then we'll be able to have much more information. Sitagliptin has good atherosclerotic safety and is neutral for heart failure, but the renal safety is not proven. Now, when we use this combination, the glycemic control is achieved by multiple mechanisms. The SGLT2 diminishes glucose reabsorption, and this action is independent of insulin. The DPP4 increases the half-life of the incretin mimetic hormone, the GLP-1, the GIP, and they act for a longer time. They increase glucose-dependent insulin secretion. They produce increased suppression of glucose-dependent glucagon secretion, and both these contribute to good glycemic control. And because these actions are glucose-dependent, they do not usually produce hypoglycemia. And the same thing is shown here, that if you use SGLT2, which is present in this combination, it will increase glucosuria, weight loss is there, systolic blood pressure drops, glucotoxicity is decreased, and indirectly it produces pancreatic effects by increasing beta cell sensitivity, and unfortunately glucagon secretion is increased. The insulin sensitivity is increased. And the DPP4 we have already talked, it has an incretin effect and effect also on the insulin and the glucagon. Now, when we look at the glycemic effects, you can see in all these components of the slide, glycemic effects is always better when you use both the drugs together than use drugs isolated. So you can see when you are using here, both the drugs, they produce greater glycemic benefits, and all these three. Whether you are using in a drug-naive patient or on top of metformin, the reduction in HbA1c, as you can see, is always better with a combination therapy, as you can see on the left side of the slide, and right side of the slide is on metformin. Again, the box will show you that reduction in HbA1c is much greater with combination. And the same thing is shown here, that when you use combination, the reduction is much better in terms of HbA1c, the fasting plasma glucose, and the body weight. And if you are using the combination, there is higher probability of achieving the HbA1c target. Again, in the left side box, you can see more number of patients achieve HbA1c goal, and the right side, you can see more number of patients even on top of metformin they achieve. And there is significant reduction in body weight. We have already talked. Reduction in systolic blood pressure, reduction in diastolic blood pressure. And the advantages of both these patients is the hypoglycemia is uncommon, which we are always desiring. So when you are using this combination, there are several advantages. We have already talked about the SGLT2 inhibitors. They inhibit glucose reabsorption. They increase glucose in the urine, weight loss, reduction in systolic and diastolic blood pressure. Hypoglycemia is uncommon. And when we use DPP-4 inhibitors, they inhibit GLP-1 and GIP. They produce greater insulin-dependent insulin secretion. They produce greater suppression of insulin-dependent glucagon secretion. They have weight neutrality, and the hypoglycemia risk is less. And again, the same thing is exemplified here. Glucose-dependent insulin secretion, SGLT2, no effect. DPP-4, they increase glucose-dependent insulin secretion. Glucose-dependent decrease in glucagon secretion, SGLT2, do not have a effect of glucose-dependent, and DPP-4 increases suppression. Increased glucagon secretion is there with SGLT2, not there with this, and increased glycosuria is there with SGLT2, not with the DPP-4, and increased beta cell sensitivity is there with both, and there's decreased glucotoxicity, and degradation or inhibit degradation of incretin hormone is only with DPP-4, and there are also inflammatory effects with DPP-4. Again, this slide shows that both agents, when they use together, will produce better glycemic control. You will retrieve HB and SARC in larger number of patients. Empagliflozin is FPG-centric, weight loss, and it is a panacea for heart failure and chronic diabetic kidney disease. While linagliptin, the tolerability is excellent, side effects are hardly encountered, and it has nothing to do with renal impairment, can be used in any stage of CKD. What is very interesting is whenever we use SGLT2, there's increased risk of genital infections, particularly. But curiously enough, when both these drugs were used, the genital infections have not shown increase. As you can see on this slide, everything is to the left of the hazard ratio. And here again, when both drugs are used, the hazard ratio is only 1.35. When you use drugs sequentially, the hazard ratio becomes more than 5. So people were wondering as to why this happens. And this happens because of DPP-4 inhibitors, which the enzyme is also inhibited in some of the bacteria. So finally, what do we get when we are using this combination? There is better HbA1c reduction, larger number of patients achieve HbA1c goals, and this is achieved with little or no hypoglycemic risk. And as we said, this is a panacea for heart failure and is a boon for diabetic kidney disease. And linagliptin is good, excellent renal safety. It can be used in any stage of CKD, and SGLT2 produces weight loss, and the genital infections are less when we use with this combination, and this combination is only once daily food. And all these newer drugs, SGLT2 and GLP, as you can see, the guidelines are studied with these, and they are making headlines in all current guidelines. Till 2018, SGLT2 inhibitors and GLP are only recommended for patients with established ASCVD, CKD, or heart failure. But from 2019, with the ESC guidelines and now with this ADA guidelines, they are recommended both for established ASCVD, CKD, or heart failure, but also for the high-risk patients who have more prone for development. So if heart failure or CKD is the predominant thing, the first choice is SGLT2 inhibitors. If SGLT2 inhibitors cannot be used, you can use GLP-1 receptor. One thing you must remember, as the GFR declines, glycosuria may decrease, but the renoprotective action of SGLT2 is still there. Large number, about 1676 patients in the cadence trial, which the data is going to be published shortly in the American Journal of Nephrology, they have also shown benefit, clearly indicating that declining GFR is certainly a determinant factor for glycosuria and maybe for cardio, but renal benefits are seen at up to much lower level, and they are seen in primary prevention, secondary prevention. You have ASCVD or no ASCVD. So that is the peculiar feature. And if the ASCVD predominates, the first choice is GLP-1, and if that cannot be used, you can use GLP, you can use SGLT2 inhibitors. We have already talked about hypoglycemia, DPP4, SGLT2, all these drugs do not produce hypoglycemia, or occasionally they may produce hypoglycemia. And if obesity is a concern, you can use these agents. And this combination is also commercially available. You can use it. It's available as 5/10, 5 Lina plus 10, and 5 Lina plus 25 SGLT2. So thank you very much for your kind attention. And we are amidst the COVID days, so we must also talk about COVID. And we are allowed back to work. But if you are going back to work, you must remember that you should avoid man and follow woman. And this is exemplified on the slide. Thank you very much.
Dr. Manoria, that was an excellent and a very thought-provoking talk. And I really congratulate you for putting the rationale for SGLT2 inhibitors and DPP4 inhibitors, linagliptin and epagliflozin, why each molecule is beneficial and why the combination of molecules have enhanced efficacy with regard to the glucose lowering and cardiovascular benefits, as well as you showed very nicely that some of the side effects or the perceived side effects of empagliflozin are actually neutralized by DPP4, particularly the urinary tract infections. Now the floor is open to questions. Manisha, would you like to take the question from the audience?
The other thing, Dr. Agrawal, you have said that if you are a diabetic, you decrease the lifespan by 6 years. If you have AMI, it decreases the lifespan by 12 years. Now, with increasing use of these agents, the SGLT2 and GLP-1, we are very hopeful this 12-year figure and 6-year figure will be scrapped down in future. So we'll see a new slide in future when there's increasing use of these agents. We hope that these slides would be modified in future.
Sir, you have to stop sharing so that
Okay. Just a second.
There is one, 2 questions has come, sir, from Dr. Asha Murthy. She's asking how about its utility in heart failure patients. You have already actually explained a lot, but would you like to add some comments to it?
See, when we talk of heart failure and diabetes, there are 3 subsets. The first subset is patients who are not in heart failure but at high risk for it. There are scoring systems available. All 3 landmark trials, the Empa, the CANA, and the Declare TB have shown 30 to 35% reduction in hospitalization for heart failure. The second subset is you have already developed heart failure with reduced ejection fraction, and the DAPA have shown that it increases CV outcome, the hospitalization for heart failure or worsening of heart failure, cardiovascular death, all-cause death are substantially reduced. The third subset of heart failure is the Empa trial is also going to be released in future. And the third subset is the heart failure with preserved ejection fraction. We do not have any trials. Trials are ongoing, and we are keenly awaiting the results of these trials.
And second question, second question is about patient who is planning to go for cardiac surgery. Which one you prefer? DP or probably DPP4 inhibitors or SGLT2 inhibitors?
If the patient is going for surgery, it's preferable that he should be switched to insulin.
Okay, sir. Yes, sir. Thank you. Thanks a lot, sir, for your comments. I guess if you have any question or kind of, then we can actually conclude the session. Dr. Amrish Agrawal, is it fine to conclude the
Yes, actually, Dr. Monaria, how do you feel that overall over the general population? Are we know that DPP4 and GLP1 they worked on the similar mechanisms, and we have an oral form of GLP1 which is going to come in the market, semiglutide. So, what do you think eventually the focus will shift from DPP4 to GLP1 receptor agonist along with the SGLT2 somewhere down the line, or we will still continue with the combination of DPP4 with SGLT2?
We are very clear that SGLT2 inhibitors, they are the drugs for heart failure and CKD. They are panacea for both these subsets. They do not modify atherosclerotic complications. Atherosclerotic complications are only modified by GLP-1 receptor agonists. So there was a plea, why not combine both these agents? But the problem with this combination, some percentage of patients are there in the GLP-1 trials who have received both these drugs. That GLP-1 is an injectable therapy, is a costly therapy, so the compliance of the patient for this therapy is much less. But now we are getting oral semaglutide, which is going to be introduced next year. A combination of oral semaglutide and SGLT2 would cover both CKD, heart failure, and atherosclerotic combination. So, because if the drug is available in oral form, everybody can take it. But injections, insulin injection, or be it GLP-1, the patient have a lot of reluctance. They see this is the end of the disease, this is the end of life, and these injections, despite education, this is not yet eliminated from the society. So when you use a combination of SGLT2 GL, it is a symbiotic effect on the glucose control, a symbiotic effect on the cardiometabolic profile, and a great symbiotic effect on cardiovascular risk reduction, which covers up all the phases, heart failure, the CKD. And so very good combination, but in real practice, this is a difficult one. But the oral tablet becomes available, I think that will be utilized for CV risk reduction. Gliptins will continue to retain space because no other drug affects. But once you are using GLP-1, I think gliptins will not be there. So you have to have incretin mimetics. One incretin mimetic has to be there for optimum glucose control.
Fantastic.
So actually one more question. Actually, both of you can actually answer, kind of respond to that. That is, sizable proportion of patients, type 2 diabetes patients, are getting detected with cardiovascular diseases. So endocrinologist perspective, if you say we can handle or can address the glycemic control properly, but do you find there is a need of active case finding in a asymptomatic type 2 diabetes patient for cardiovascular diseases? Is it possible that, or is it required active case finding in asymptomatic type 2 diabetes patients?
The usual practice is vast majority of diabetic patients and even the endocrinologists, the attention is focused on glucose control, glucose. The patient himself focuses on glucose control, and they are sent to a cardiologist very late in the disease when you already developed atherosclerotic complications. And you can die with a HbA1 6.5 from an acute myocardial infarction. So glycemic control is very important, but atherosclerotic cardiovascular disease is entirely a different ballgame. You have to take measures to minimize that also. In practice, usually we see patients are referred. So cardiologists and diabetologists should join hands. If there's problem in joining hands, the cardiologist should learn about diabetes and the diabetologist should learn about cardiologists. And then the patient will be able to be managed much further. Early detection is of paramount importance, no doubt about it.
Okay, so I think we'll conclude the session right now. It was excellent speech talk from both the speakers. Thanks a lot for taking the time out from your busy practice. I understand a lot that it may be very difficult, but thank you. It was insightful talk, and thanks Dr. Amrish sir also and Dr. PC Manoria also. We'll conclude the session. Thank you.
Thank you, Dr. Amrish. Bye-bye.